So we're going to give everyone just another minute to sign in, and then we will start. We will be starting in just a minute. Okay. So welcome everyone to this webinar, Medicaid Structured Family Caregiving, Enabling Caregivers to Make Caregiving Their Primary Focus. I'm Neva Kay, a Senior Policy Fellow here at NASHP, and I'm going to be moderating today's webinar. Next slide, please. Today's webinar draws on a body of work I completed late last year, examining how states were implementing structured family caregiving in Medicaid for older adults. I started this work at the behest of policymakers in Nevada and drew from the experience of Medicaid officials in 3 states, Georgia, South Dakota, and Missouri. It is our hope that you will find the information we gathered useful to your own efforts to support family caregivers. Next slide. As you can see, our agenda for today really reflects this work. First, I will provide an overview of our findings. Then Rena Cox, who is the Bureau Chief of Long-Term Services and Supports at the Missouri Department of Health and Senior Services, will discuss Missouri's approach and experience. And then Charles Duarte, who is the Public Policy and Advocacy Director of the Alzheimer's Association of Northern California and Northern Nevada, will offer an advocate's perspective on the program and report on progress in Nevada. At this point, I would like to thank our funders for their generous support of NASHP's work in family caregiving, including this webinar. They are the John A. Hartford Foundation and the Administration for Community Living. This webinar would not be possible without their support. Next slide. I need to cover a few logistics before I begin my presentation. First of all, we have reserved some time for questions after each presentation, also at the end of the webinar. You can send these in via the Q&A function on your Zoom web desktop. But do bear in mind, you don't have to wait until the discussion time to send in your questions. Instead, I encourage you to send questions in as they occur to you during the presentation, and we will respond during the question and answer time. And finally, we do ask that at the close of the webinar that you please follow the link to the very brief survey to share your feedback. Next slide. With that, I'll turn to my presentation. As I said, today's webinar draws from work I recently completed examining state structured family caregiving programs for older adults. Specifically, we at NASHP started by identifying 7 states that, as of August 2022, covered structured family caregiving, or SFC, services for older adults within their Medicaid program. Many of these also offered the service to people with disabilities. These 7 were Connecticut, Georgia, Indiana, Louisiana, Missouri, North Carolina, and South Dakota. Since that time, representatives of Idaho and Massachusetts have also told us that they cover the services in their Medicaid programs, for a total of 9. From those 7, we chose 3 states that represented a diversity of states and structured family caregiving policies and experience in structured family caregiving. They were Georgia, Missouri, and South Dakota. Georgia and South Dakota both offer the service to both older adults and people with disabilities. You need to go back. There we go. And people with disabilities. Missouri offers it only to people with Alzheimer's disease or a related diagnosis. For these 3 states, we reviewed documents and interviewed state Medicaid officials in order to gather detailed information about their policies and learn of their experience in implementing and operating structured family caregiving programs. The information I'm presenting today is drawn from that work. I'm going to start by defining structured family caregiving and discussing how it differs from other services, then dig a little deeper into the key elements of the service and close with key takeaways we heard from state officials. Next slide. So, what is structured family caregiving? There were common elements that defined the structured family caregiving package across all 3 states, indeed across all 7. And those are the ones identified here. Essentially, structured family caregiving is a package of services that supports home and community-based services, HCBS, waiver participants, primary caregivers, and includes payment, individualized training based on the needs of the waiver participant, coaching, backup or respite care, and other supports for the caregiver. Next slide. So, structured family caregiving is delivered as part of a 1915C home and community-based service waiver, and it can be either incorporated as a service within an existing waiver or as a standalone waiver. And among the 3 states we examined most closely, Georgia and South Dakota chose to incorporate their structured family caregiving services into a broader waiver that also covered other home and community-based services. This enabled those states to leverage those other services to support the caregiver waiver participant duos. For example, when needed, South Dakota will provide in-home nursing services in addition to structured family caregiving. These 2 states also reported that adding the service to an existing waiver eased implementation because waiver care planning and administrative structures were already in place. Missouri implemented its program as a standalone waiver, which enabled it to design policies to meet the specific needs of eligible people. And you'll hear more about that from Rena in a few minutes. Next slide. So when I first described structured family caregiving, one comment that state officials and others almost invariably make is that we already cover some of these services, sometimes all of these services. How is this different from that? And indeed, they're correct. States may offer aspects of structured family caregiving as individual waiver services, but a few factors set SFC services apart. First, the services are managed as a single package by an agency, usually a home health agency, that frequently checks in with the caregiver to both provide individualized support and ensure that services are being delivered appropriately. Second, services are provided in a home, and I emphasize a home, where both the waiver participant and the caregiver live. The caregiver has a significant relationship to the participant, often a relative or a spouse. So it is really services being delivered in a home by a family member who is almost always has been providing those services before entering or receiving the service. Third, payment to the caregiver is usually made as a stipend that is passed through the agency, and usually that stipend is federally tax-free. Finally, at least for older adults, it's intended really for waiver participants who do not or cannot self-direct their services, thus Missouri's focus on Alzheimer's disease. Next slide. Now I'm going to dig a little deeper into the SFC service package elements. Next slide. Let's start with payment. As I said, in structured family caregiving, payment to caregivers flows through agencies that are responsible for supporting and overseeing the caregiver's work. All 3 states pay participating agencies a per diem and require the agencies to pass on a set percentage of their payment to the caregiver. This varies among the states, but was at somewhere between 50 and 65% of that per diem is passed on to the caregiver. All 3 states peg their SFC payment amounts to the cost of providing the type of service They anticipate it will replace. Georgia, for example, bases SFC payment on the cost of providing extended personal support services, while South Dakota ties it to assisted living rates. And an important related note to this, all three states anticipated that providing SFC services would prevent the need to provide some other services, which helps the Medicaid agency afford the cost of adding the SFC services. In order to ensure that they realize those savings, they have put policies in place to prevent separate payment of those other services that the caregiver is anticipated to provide. South Dakota, for example, specifies that it will not provide separate payment for meals, homemaker services, and/or chore services to HCBS waiver participants who receive structured family caregiving services. And this is really meant, as I said, to keep the service budget neutral for the agencies. Next slide, please. Now let's take a closer look at the non-financial caregiver support. Starting with individualized coaching and training based on current and anticipated participant needs. The focus on anticipated needs is really important, particularly for the population that we were interested in, that population of older adults, as often structured family caregiving in that situation is provided to waiver participants whose capabilities are declining. And the focus on anticipating the participant needs ensures the caregiver is prepared to identify those declines quickly and respond to them, which really helps manage the decline. Both Georgia and Missouri require agencies to deliver at least 8 hours of individualized training per year. And further, that training must be based on the specific assessed needs of waiver participants. South Dakota takes it one step further. South Dakota requires agencies to conduct a comprehensive caregiver assessment and establish a plan for educating, coaching, and supporting every caregiver who is receiving SFC services. All three states also require the caregiver to keep records of what they do. These agencies regularly review the caregiver notes to identify new needs and provide oversight. Georgia, for example, requires agencies to offer web-based support for tracking information such as daily notes, and that information is then shared between the caregiver, the care coordinator, and others to really continue the support for the caregiver. And then finally, agencies are required to provide backup or access to respite for the caregiver so that caregivers can take a break from their duties or to fill in when the caregiver cannot provide their usual care for some reason. Next slide. So what did the state officials report from their experience with these programs? First of all, states have found that the SFC services are achieving their purposes. Waiver participants are able to receive the personal care they need in their home from someone they know and trust. This has led to successful program growth. South Dakota, for example, saw enrollment grow more quickly than expected. This state implemented SFC in 2019, and by July 2022, over 200 waiver participants were receiving the service, a level administrators had not expected to achieve until 2026. Administrators attribute this achievement to family caregivers' eagerness to make caregiving their primary focus while still being able to pay their bills. Secondly, they found that states required funding to pay for the services themselves, but both Georgia and South Dakota were able to offset those costs by reductions in other services, as I mentioned earlier. The three states that I spoke to were also able to implement the new service without additional administrative resources. In other words, they did not need to hire more case managers or make major changes to their service authorization or claims payment services systems. Third, participants and caregivers frankly chose to receive the SFC services for the payment, but they also find the support services valuable. As one interviewee observed, the stipend enabled participants to have a sense of normalcy because it allowed family caregivers who are already living with and providing care to participants to provide that care without worrying about how doing so would affect their family's financial situation. However, interviewees from both Missouri and South Dakota went on to describe some of the key supports that caregivers valued, such as having access to a nurse to help them better understand their task, and also some emotional support for the caregiver, one offering an example of how the agencies connected the caregiver to support groups. And finally, we heard loud and clearly that the agency that administers the package plays a critical role. I know you've heard this throughout my presentation, but the 3 states that all administer SFC services through agencies that pay, support, and oversee participants' caregivers. And these states all reported that doing so not only minimized the need for state administrative resources, but it gave them reassurance that in each case, the caregiver would be able to safely care for their loved one, and if that situation changed, it would be quickly identified. Next slide. So in closing, we found that SFC services can be a very effective way to enable family caregivers to make caregiving their primary focus and increase both their ability and their confidence in that ability to care for their loved one, especially as the condition progresses. It is my hope that the information you hear today will enable you to assess whether SFC is a good policy option for your state, and if it is, help you design an effective program. Thank you. And next slide. So with that, I'd like to take a brief pause to see if you have any questions for me. Remembering that you can use the chat. Oh, I see we have questions in the Q&A chat. Kelly Hedrick asks, will this information be relevant to those with developmental and intellectual disabilities who receive long-term care, home and community-based services, or just seniors? And I would say that while our focus was on seniors and older people, that many of the same issues arise with those with intellectual and developmental disabilities. And I know there are similar programs in place for that population, quite frankly, with very similar policies in place. It was just for a different population. So yes, that is true. Amy White asked if it was FICA exempt, and I have to be honest and say, I don't know that. I only know that there is an IRS bulletin, section 131 of the Internal Revenue Code, that discusses why it is federally tax exempt. Camille asked, can a legally responsible adult be the paid caregiver under SFC? Yes. I mean, they can be. Georgia actually made the decision for a while not to allow that, but during the pandemic, they changed that, and in other states, they are allowing the legally responsible adult to be the paid caregiver. And part of the reason I think that that is something that works under this particular service is that it's not provided under self-direction. It is managed by an agency. So there's assurance that even when it's a legally responsible adult doing the caregiving, that there's somebody who is right there making sure that things are being done appropriately. And the question we always get, yes, we will be posting the recording and slides after the event. Are adult day centers eligible? Oh, Kathy asked, are adult day centers eligible to serve as an agency? That would be a state level decision. And so I think it would be best to wait and ask that question of Rena. And I'm not sure about the question about rate sharing. That we might elaborate on later as well. And so Misha is asking, can you share a little more about what it means for an agency to oversee a family caregiver? What I mean by that is that the agency not only pays the caregiver, but is in contact on a regular basis. How regularly depends on the needs of the patient and on the requirements of the state, to do training, to make sure that the services are being delivered as appropriate, and so that the care is being provided appropriately and safely. And Marge asks, is SFC budget neutral to state programs because previously offered services like meals and chore servers are replaced? That is correct. That is exactly why it is budget neutral. And as a matter of fact, particularly in Georgia, what they did is they pegged qualifications for their SFC services to qualifications for extended personal services, and then said that anybody in SFC was not going to be able to get those personal services because they were being paid for directly. And I think I have time for one more question before I need to move on, which is a question about model legislation, which I think I'm going to let Rena and Chuck address. And definitely these others, I think we can come back to these in a bit. And so with that, I thank you. This has been great. Let me see. And so I'd like to introduce Rena Cox, who is going to present Missouri's experience in implementing structured family caregiving. And we will return to these questions afterwards. Trust me, we won't lose them. Rena?
Good afternoon, everyone. I am very appreciative to be able to speak with everybody about Missouri's experience with the structured family caregiver waiver. Go ahead and go to the next screen. So why did Missouri decide to go with the structured family? Go back one screen, thank you. Decide to do the structured family caregiving waiver. Go back one slide. There we go. So as we know with our population is starting to age. Go back to the need for structured family. There we go. Now it keeps moving back and forth. Anyway, so need for structured family caregiving waiver. The reason why we've done it is the state of Missouri realized that we needed to be able to serve our population that has Alzheimer's and dementia. And, you know, we didn't really have any services that really necessarily directly met their needs. We did have some that we could do some things under our age and disabled waiver to help with like respite services. And we could help with, you know, meals and those kinds of things, but we didn't have one waiver that would necessarily be all encompassing with the needs for our individuals that had Alzheimer's and dementia. And that was really important to us because we want to make sure that individuals who do have Alzheimer's and dementia has that family member or that daily caregiver that they have in the home, providing these services to them and making sure that they have that constant companion, somebody there that can help with de-escalating any situations that may come up, work with those behavioral changes as they occur, and just be able to work with them on an ongoing basis. And, you know, once somebody starts having Alzheimer's and dementia, there's always that concern that you know, anybody who comes in the home, even if it's somebody they may know, could be a stranger, and they can cause all of those behavioral issues to come up. So we saw as a state that it's really important to really start working with this population. And we worked very closely with the Alzheimer's Association. They were a stakeholder with us with the development of the waiver, and they were engaged throughout the entire application process. So they gave us feedback, they gave us input. They helped make sure that the word got out there that we were trying to develop this waiver and help us with trying to get the statute written up really well. To try to help meet the needs for our participants. And really we really just wanted to make sure that our individuals, our participants in our state was getting the best services that we could. Go ahead and go to the next slide. So once we started to work with the legislation to make this happen, we did work with the Alzheimer's Association. We worked with the legislation. We started to work on a statute, and in 2019, we had Senate Bill 514 pass, and it was our statute was 208.896. In this, it very clearly defined what we were going to do, for our participants in the way of how this actual statute, how this actual waiver worked for them. It's very clearly defined. A lot of the things that are in our waiver is very, very clearly defined within that statute itself. Things on there, we had in there that this is a waiver that has 300 slots. That's clearly defined within that waiver. And that's another thing that was in our statutes that we had to ensure was that we had to have our structured family caregiving waiver actually established before July 2nd of 2020. Go ahead and go to the next slide. So within that statute, there was things that were talked about, like our diagnosis. So the diagnosis has to be an Alzheimer's or a related dementia disorder. And it's actually one that's defined by our statute 172.80. So it's very clear in there. This diagnosis has to be by a licensed physician, and they have to be licensed in the state of Missouri. So that's all in our statutes. Another things that are in the statute is that the providers are in-home service providers. So I did see a question about adult daycare. That would be a no within the state of Missouri. The providers actually have to be licensed to provide personal care services in the state of Missouri in order to get the additional addendum to provide structured family. The caregivers, they are actually employees of the provider. So the provider has that administrative oversight of them. The caregivers are the ones who do the electronic documentation every day that goes to the providers, and they oversee all that. And they also will provide training to the caregivers, to the needs of the participants. So they don't actually have to do the full-on training that's required of all of our other caregivers within the state of Missouri that provide personal care, but they have to be trained for the participants' needs themselves. When it comes to our caregivers, it can be anyone. So legally responsible adults, it can be spouses, it can be guardians. As long as they live full-time with the participants, there is no limitation on who we can actually have in the home, who we can actually have as that paid caregiver. The only thing is they have to be able to pass a background check by our Family Care Safety Registry. So that is the only requirement. Other than that, they have to live with them 24 hours a day and be providing that care to them 24 hours a day. But they only have to pass that background check. When it comes to our daily payments, this was already kind of talked about. We do have our 60% of our nursing home cost cap is where they're at, which is that $74.76 per day. And then the provider is able to keep up to 35% of that daily reimbursement rate. So they can keep up to 35 and pass on 65%. But it is the provider's decision on the amount that they keep. They just cannot pass on, they cannot hold on to more than 35%. The services that is being provided to the participants is all encompassing. So they're going to be doing their homemaker, their meals, they're going to be doing their activities of daily living. So bathing, dressing. They help them with transportation to and from any of their appointments or for running errands. They can help with some medication setup, but some medication, however, it's limited to what is allowed by our state law, which means the paid caregiver in the home is not allowed to set up medication. If they need medication set up, they do have to work with the agency to ensure that that is being done. Next slide. So we actually were able to work very quickly and get our waiver approved, and it was supposed to start July 1st of 2020. Of course, we had that stumbling block. COVID hit, and everything happened in 2020, and because of that, our waiver was not funded to start July 1st of 2020. So we didn't actually get it to start until July 1st of 2021. Where we're at right now is we currently have about 108 participants. Actually, I heard today that it's a little bit higher than that. But that was where we're at last week when I was pulling this together. We did develop our waiver as a standalone waiver. It's not mixed with our age and disabled waiver. Like there's a lot of other states that they have it with their disabled waiver. Because our disabled waiver is actually limited with a starting age of 63, and we are actually starting this structured family at the age of 21. There was an issue with that basic requirement, so we ended up doing it as a standalone waiver, and it works really well for us based off of how the statute is written as well. Go ahead and go to the next slide. So what are our biggest successes? Well, you know, we were able to work with CMS to approve getting the spouse and legal guardian to be able to provide the services. None of our other waivers have that ability. So we were really happy as a state that we were able to get those spouse and legal guardians approved. The other thing too is, you know, this waiver assists participants to remain in their homes, and quality of life is so much better when they're in their own homes and they're being cared by people they already know, and you know, they have that relationship with them already. Some of the lessons that we've learned, I think the biggest lesson we learned was being careful about limiting who is able to do the diagnosis, since as we have it actually says the state of Missouri. It's very limiting in some of our areas, like in the Kansas City area or in the St. Louis area, where people tend to go to facilities that are outside our state borders. It is a little harder to get those individual services since their doctors are not licensed in the state of Missouri. So that we found is something that we would like to look at trying to get changed in the future. And also, you know, being careful about the limiting of the diagnosis. We do have individuals who probably could, that really do need our services, but because we have to have Alzheimer's or related dementia, we sometimes have to turn people away because they don't have that diagnosis. And even though we know that this would be very, very beneficial for them. We also learned that we need to make sure we're very clear about our expectations of both the caregivers and the providers themselves. You know, for example, how do they develop that care plan to ensure that they are working within minimum wage and that they're doing right with what's going on with the Department of Labor? So that's one area that we had to do a lot of research after the waiver went through to figure out how all of that really plays in together. Also, you know, that the trainings, making sure that they know what kind of trainings do we really need, and how does those trainings work. And, you know, when we're saying related to the participant, that sometimes is very vague, and it would be good if we were able to clarify that a little bit more with them so that providers really understood their role when it comes to trainings as well as documentation. When we talk about documentation, we really just say that they just have to do electronic documentation, but we don't really talk about how all of that works. And so, you know, providers who have never had to do that before had to develop all of their own systems, and everybody was just trying to do everything all at once because the new waiver came on board and everybody wanted to start using it. And then we came to these roadblocks of, well, nobody wanted to take them because they didn't understand what their next steps were as providers. And so we had to work through all of that. So being more clear from the get-go and making sure that you are able to really explain those to the providers from the very beginning, I feel would be very, very important. Go ahead and go to the next screen. And I know there's a lot of questions. And so I was thinking we would just spend some time answering some questions. You know, I am always willing to talk to anybody who might have any questions. Feel free to reach out to me by email. I have actually had a lot of conversations with different individuals throughout the state and throughout the country, that is. And I am always willing to talk about structured family. It is, you know, our newest waiver, and it's exciting to kind of see how it's growing. So, but if we want to go ahead and try to answer some questions.
Okay, that's great. Thank you, Rena. That was great. I can hand some of these kind of in order they came in. We'll start with From Anne, is Missouri thinking of expanding other waiver populations given their positive experience? So in other words, are you thinking about expanding your program?
We always have thoughts about expansion on this program. With it being new, I definitely have some ideas of where I want to go from here, but we don't have anything really kind of set in stone. I think some of the stuff I want to change right now is just like I am trying to work on that being licensed in the state of Missouri. I think that's very limiting. So I know I'm trying to work on that, and then we can start working on it. But I do think that this program, what we have today, is probably not going to be the same program that we have in a few years. I do think at renewal, we'll be making some definite changes to the program.
And how did states get the approval from CMS given stated limitations on paying legally responsible adults, which you did list as one of your successes? I want to know how you got that.
So I wish I could tell you. I actually, we had somebody else who wrote all of the waivers. And honestly, I remember having conversations with her at the time, and she just said that she was just going to make the request and see what happens. And CMS never questioned us. So I think they were really on board with it. It just, we sent it up and said, this is what we want to do. And they said, okay, that's fine. So there wasn't any magic wand to it. They approved it. So I don't think they had a lot of concerns about it from CMS level.
And somebody also wishes to have the program be independent care coordinators versus home care agency. We don't have agencies in all areas. I think this kind of comes down to is what did you think about which providers were going to be able to ask to provide these services, and kind of how broad is that mandate?
So I will say that is part of the statute, and so we didn't have a lot of when it comes to the managing over the waiver itself, we didn't have a lot of options on that. It does fit well with our personal care services agencies though, and so I think it's an appropriate fit for the state of Missouri, but I could see in other states that it may fit better other areas. And I do know, having done research for other states, they do them in different ways for different states. But for the state of Missouri, the personal care agency was the way to go for us.
And we are getting more questions coming in about the agency as the employer, FICA exempt from Amy. And I do want to pause and say, we only have Missouri speaking here, and I know that in the other states I looked at, Georgia and South Dakota, things kind of played out differently. But I think, Rena, if you could share your experience on that, it would be great.
I'm sorry, what was that? You cut out a little bit.
It's about the agency being the employer. And I think it's some of the struggles you were talking about having right now with the Department of Labor. Yeah,
so we do have it where the agency is the employer. I do know, having talked to some providers who wanted to come into the area, that some other states may actually have them as contractors and not employers. But for us, it works well for us to actually have them as the employers. It helps us with the administrative oversight to ensure that they really are there getting all of that information. And making sure, that the family is caring for the participant appropriately. There was a lot of concerns with Department of Labor and making sure that, we're not violating overtime laws, and making sure that the participants are actually, that the caregivers are actually getting paid appropriately, and the care plans themselves. And that honestly is still some issues that we're working through today as well. It's really vague in the way that is kind of written, and so we're trying to work with with the providers to ensure that Department of Labor laws are being followed. So that is still kind of an issue that we're working through.
It is, and you are correct. Some of the other states consider the caregivers contractors. That's why the emphasis on being a stipend and thus qualifying for that federally tax-free provisions. But I think with that, we should probably move on to Chuck's presentation to make sure he gets his full time. So thank you. That was great information. And so, Chuck, I'd like to
Yeah.
introduce you and to offer an advocate's perspective on structured family caregiving and discuss the progress Nevada has made toward implementing your own program. So, Chuck,
Yeah.
wait.
Thank you, Neva. Appreciate the opportunity today, and good afternoon, everybody. I think it's probably afternoon, except for our friends tuning in from Hawaii. But yeah, my name is Chuck Duward. I am a policy advocate for the Alzheimer's Association here in Nevada. And you know, this work started about a year ago in some dialogue with our Alzheimer's Association support group facilitators, and you know, it was I learned a lot sitting in with and talking with them about some of the experiences that our caregivers were having, and particularly family members who were having to give up a great deal of their time, their careers, their financial security, their social lives, and become almost full-time, if not full-time, caregivers to a family member. And the struggles that they went through were really what highlighted it for me to start looking into options that might be available to really support them in their effort to take care of somebody and keep them at home, delay those nursing home placements, and avoid unnecessary hospitalizations and emergency room visits, which all cost the state Medicaid agency money. And so my discussions started really with Neva and the work that she put out on a study from NASHB on structured family caregiving. And that caught my eye, and invited Neva to do presentations to our Commission on Aging here in Nevada. And ultimately, the work resulted in us having some legislation. So if you wouldn't mind going to the next slide. So, you know, of course, we were looking at this as the Alzheimer's Association from the standpoint of caregivers. And, you know, here in Nevada, we've got about 50,000 people living with dementia. We're not a really big state population-wise, but we've got 48,000, an estimated 48,000 caregivers who aren't getting paid. And as I said, you know, their lived experience really came through with discussions with their support group facilitators about what they were having to deal with family members who had dementia and were progressing through the stages of Alzheimer's disease. We have the third fastest rate of growth of dementia in the nation, right behind Vermont and Arizona. And in 2020, the Alzheimer's Association estimated that Medicaid here in Nevada spent over $200 million on people with dementia, most of which was spent on long-term services and supports. Next slide, please. So as I mentioned, you know, we have a history going back about a year and looking into this and looking for options to help better support family caregivers. And those discussions included presentations to one of our legislative committees. So here in Nevada, we run a biennial legislature. It's currently in session. It's in session every odd year for 120 days only. So we're right in the midst of, or right at the start of our legislative session. But the work really started with an interim committee on senior citizens and a presentation that I did along with one of our care support group facilitators, talking about the need for this program and the options that were available to us to better support family caregivers. The concept stuck. And as I said, you know, we invited experts like Neva Kay to present information to our Commission on Aging. I happen to chair the legislative subcommittee of our Commission on Aging, and Neva did a presentation for us last April. And again, that really helped to solidify this idea as being one of the policy priorities that the Alzheimer's Association really wanted to pursue. It also gained the support of that Commission on Aging. In July of last year, I submitted a bill draft request, a form that basically described what we wanted to do. And in particular, I highlighted the work out of Missouri, which I'll talk about in a bit. And then in August, the interim committee adopted this proposal for structured family caregiving as a committee bill. And it's moving forward right now through our legislative session, our 2023 legislative session, as Assembly Bill 208. And then, as I've mentioned, we did gain the support of our Commission on Aging, and have received a letter from them supporting this initiative going forward. Next slide, please. So, again, we didn't try to reinvent the wheel. I like I said, spent some time talking with NEVA, and looked at the work that was already done in states like Indiana, Georgia, and Washington, and used Missouri's legislation as sort of a model. And as Rena Cox was indicating, that may not be the final answer in terms of what their waiver looks like ultimately, but it was a good starting place for us. And so that law that out of Missouri was used to basically establish the bill that we have going forward. And we are creating a standalone dementia-specific HCBS structured family caregiving waiver. And just like in Missouri, they'll hopefully have their choice of caregivers, including legally responsible individuals like spouses and guardians. Again, just like other states, we were really looking at a way of providing those additional supports, including respite and focused training based on the Medicaid enrollees functional assessment or functional needs. So there will need to be some processes put in place in order to identify that through a functional assessment, and then from there gauge the training. One thing I didn't include on this slide, but it's probably important to mention, is that we are requiring that the family caregiver be an employee of a personal care agency or an intermediary services organization. So either a PCA agency or an ISO. We're looking, like other states have done, to try to streamline the enrollment process for family caregivers. And then the law actually stipulates that 65% of payments are passed through as a stipend to the family caregiver. So we're looking at a per diem or daily stipend for them. Next slide, please. So there's been a lot of discussion with state staff, and in fact, it continues. After submitting these slides last week, I've gotten some additional information and some concerns expressed from state Medicaid agency staff about how the bill might work. And so, I've been talking with them, with the state Medicaid staff, as well as our aging services staff, about how this works. In Nevada, we're structured in a way where, Medicaid has overall a responsibility for financing and administration of the waiver, as well as working with CMS on any waiver applications or amendments. But the day-to-day operations of all of our home and community-based programs are done through the staff at our Aging and Disability Services Division. They're all under the roof of our Nevada Health and Human Services Department, but they do split up their responsibilities. And so, we've been talking with them. They've reviewed the draft bill, and there were some initial concerns that came forward. They were concerned that this proposal particularly wouldn't be cost neutral, and I'll say something about that in just a minute. Concerns about some of the business rules that may limit their ability to restrict pass-through percentage of Medicaid payments to caregivers. I don't know the details of this concern, but it was raised in one of our conversations. Also, the medical determination to require a confirmation of a dementia diagnosis, that may be an issue. And I think, as Rena described, hopefully during the implementation process, when the rules are developed around this, that we can be more flexible in terms of who can actually provide that diagnosis, because, like in Missouri, we've got a lot of border towns that where people receive services or may get their diagnosis outside of the state of Nevada. There may be some changes in the Medicaid management information system. We've got some estimates what that might be, as well as creating a new provider type. Although I think that with the use of a personal care agency or ISO, intermediary services organization, those issues are not as important. I think the biggest issue that's kind of popped up over the last several days is that the department doesn't feel that this is going to be cost neutral. They put a pretty significant cost estimate on the bill in the tens of millions of dollars. And so that's a discussion that we have to have. I think the struggle or challenge that the department fiscal staff have is that it's understanding the program, but also trying to find information that will help them tailor their cost estimates to the target population that we're talking about, which, as Rena described, is really a fairly narrowly focused funnel where somebody has to be Medicaid eligible at an institutional level of care, a nursing facility level of care, first and foremost. Second, they have to have a dementia diagnosis, which further limits that funnel. And then third, they have to have a family care partner that's going to be willing to be or is already living with them on a full-time basis in their home. So all of this sort of narrows the funnel down to a program which we think at the Alzheimer's Association is relatively small, but will be an effective tool to help support family care partners who live with somebody with dementia. So I think the challenge again for the department is really trying to identify that eligibility group and to apply appropriate cost estimates to that. So I'll continue working with them on that issue as this bill moves forward. We have a hearing coming up on Monday before our Assembly Health and Human Services Committee is hearing this on Monday, March 13th. It'll probably get referred to Assembly Ways and Means, as the Money Committee will have to take a look at the fiscal note that the state has imposed on this. But hopefully, like I said, I'll be able to have some discussions with the state to reduce the current fiscal costs that they've put on the bill. Next slide. And I think that's it. So this is my contact information, just like Neva. I'm happy to answer any questions. We have a national state affairs expert, a gentleman named Carter Harrison with a great deal of Medicaid experience at our national office. And so you can email him or contact me. I've got a little bit of Medicaid experience. I was an administrator for Nevada Medicaid for 12 years and the Hawaii MedQuest program for 3 years. So I've had to deal with CMS and waiver programs for quite some time, but again, happy to answer any questions as Carter is as well. So with that, I'm happy to take any questions, or as if Neva wants, open it up to all the questions there for Rena, myself, and for Neva.
Yes, thank you, Chuck. That again was great information. You're making really good progress. Looking forward to hearing more about that and success. We do have some time to take some questions, and we have some good ones that came in from the audience. And I think that I'm going to start with this one from Cheryl, which is, what motivated the states to move towards structured family caregiving? Did they have workforce or capacity issues they were trying to address? And how did this conversation get started in these states? And I think Chuck, you probably answered that for Nevada in your presentation, but Rena, did you want to address that?
I sure can. So, actually, we got this approved back in 2019, but the discussions to actually get structured family going started as far back as 10 years before that. It really was a driving force with our Alzheimer's Association within our state to get this going. It did not have anything to do with workforce or capacity issues. It really did have to do with let's take care of our individuals inside the home that really do better with loved ones, known acquaintances caring for them instead of having strangers come in. With the way our programs worked, this was the first time we allowed people who could not self-direct to have a loved one care for them. And so that was really important that we took that, we eclipsed that border right there and actually started saying, yes, we know that our participants need their loved ones caring for them, and that this was a needed program within our state.
Thank you. And actually, that's something I've heard from the other states I interviewed in part of this, that as a matter of fact, Georgia was the one that really emphasized how the need for the service arose from the families and from trying to serve the families and enable them to provide care in the way that they wanted to. Let me see, what else do we have here? So what kind, Anne also asked what kind of services were excluded to assure budget neutrality. I want to emphasize that. Rena, do you want to talk about that?
No, you go ahead.
Okay, so I want to emphasize that when I was describing that, it actually applies most clearly to Georgia, because when Georgia was estimating and establishing the payment rate they were going to pay for structured family caregiving, they based it on the cost of extended personal care services. And then once somebody got the structured family caregiving service, they said, now you can no longer get this extended personal care service. So they knew that was the one-for-one transition. Not Missouri. South Dakota took a little different because they based their rate on assisted living, but they looked at what kind of services did they anticipate the caregiver was going to expect, and was it reasonable to expect, like homemaker services and others, and then excluded those. I do want to emphasize, though, I not to give you the wrong impression, because I know there's a question later here about can participants still access other services once they are in structured family caregiving, and that also differs by states. So in South Dakota and Georgia, once somebody gets structured family caregiving through a home and community-based services waiver, there are specific services within that waiver that they are no longer eligible. But other than that, they are eligible for the other services that are covered by that waiver, and they're also eligible for all services that would normally be provided under the Medicaid state plan. And I know there's a different answer to that in Missouri. Rena?
Since we did go with a standalone waiver within the state of Missouri, once we have somebody authorized for structured family, they are not eligible to receive any other waiver services or state plan services within the state. We do, all of the care is provided under our structured family, and unfortunately, structured family is the only thing that's underneath that waiver. So we don't have any other services that we have generated underneath structured family at this time.
But they would still remain eligible for other state plan services, right?
No, actually, it's all encompassing. So they get the state plan care that we would normally provide under structured family, meeting all of their activities, daily living under that structured family.
But like physician services and such?
Sorry, what was that?
Like physician services?
Oh, yeah, those kinds of things. Yes. Yeah. I'm just thinking any home and community-based type services that is all encompassing with this waiver.
And then also a question for you from an anonymous attendee. Can a participant have more than one caregiver?
No, they can have one primary caregiver, and then they can have a backup, an alternate caregiver, but it is just one person that's providing the care to them. And they do have to show that they're providing that 24-hour care. We do have it where people are like, well, I work, so I need somebody to come in while I'm working. And no, unfortunately, this person is the one who's providing that 24-hour care.
Okay. Thank you. And there's also a question here to ask to review the payment and pass through again. So I don't know, Ella, can you go back to the slide that I had that showed the payment rates? Because I think that will be helpful to this. So essentially what it's done, each state has established a rate. South Dakota established 3 of them that is a per diem rate, and each of them pegged it to a specific service that was already covered in the package. Georgia, as I said, pegged it to their cost of extended personal care. South Dakota pegged it to the cost of assisted living. And I think in Missouri, Rita, you pegged it to nursing home cost, right? You said.
Yeah, it's 60% of the nursing home cost.
Right. And that's essentially what all the states did, is they said, this is what we think the service is going to be like. We're going to tie the amount we pay to that type of service. Then what states do, and I express it as requiring the agencies to pass on a specified % of the payment to caregivers. What states often do is express it the other way, which is saying agents can retain X% of their per diem for administrative cost. And in Missouri, that's 35%, right? And in
correct.
And in the other states I looked at, one state, they said they could retain 50%, but that's a state-specific position decision. And so then the agency can retain just a set amount and the rest at most, and the rest of that has to go on in the form of a stipend to the participant. And I believe those stipends, some of them are a daily rate, but now in thinking back to them, I believe that some of them are paid more on a weekly basis. I don't know how it works in Missouri, Rena, but maybe you could talk to that.
So they're based off of how the actual agencies pay. Some agencies pay, every other week, some pay monthly. So it's just based on how the agencies does it themselves.
And with that, we are out of time. We've actually gone a minute over. So I just want to close by thanking you. And Ella, if you could go back to the end. As I said, these will all be posted, and so you'll be able to access these lists, but we also are going to provide you access to some of the other resources that NASHB has on family caregiving, so that you can take a look at that, and hopefully that will support your efforts. And then I want to close by one more time thanking the speakers. Chuck and Rena, you did a fabulous job. I would also thank our funders, John A. Hartford Foundation, and the Administrator for Community Living one more time. And of course, NASHB's own Ella Taggart for all of her hard work and support of today's webinar. Thank you so much for your participation, and enjoy the rest of your afternoon. Goodbye.
Thank you. Have a good day.
Bye, everyone. Have a good day.